Hello, everyone. I'm so glad that I can give you two my preferable lectures that are related to blood clot and infection. I hope you have been doing well despite of all coronavirus problems, and we are getting our vaccinations, but there are still a lot of variant viruses, so there is always some risks. And as you know, that the infection is sort of a foundation of stimulating all kind of diseases, including thromboembolic diseases. Vice versa, thromboembolic diseases can also possibly triggering infections. Recently, several vaccines apparently produce some thrombosis, and that is not clearly well studied yet, but certainly it is considerable that adenovirus apparently damage platelet or platelet function, and then we can expect blood clots. So it is again important to understand and continuously study on these two subjects, thromboembolic process and also infection and inflammation. Okay, this is a simple diagram to show a blood flow in healthy vascular system. As you see, all red blood cells are flowing, but in the thromboembolic process, there are accumulation of blood clots together. That's called thrombus. And certainly some other component attached to the platelet, fibrin and some calcium, etc., makes all certain vascular disease such as atherosclerosis. So this is a recent publication. As you see, the blood clot in pulmonary sort of artery, that's a pulmonary emboli. This clot is in the femoral vein, that's a venous thrombosis. The surface of lung look okay, and so this is from the autopsy of the patient who died of coronary virus infection. Now, first we have to define clearly what is a thrombus. Thrombus is a vascular clot, as I mentioned. There are arterial thrombus or venous clot. Difference is a platelet accumulation abundantly is in arterial system, and the fibrin, a red cell, is in the venous system. When this clot travels around, we call it emboli. Embolus is a very small clot, blood component or air or fat to pass through the venous vascular system and make a some obstruction of arterial system is called embolism, like a pulmonary emboli. Now, atherosclerosis is a forming atheroma. Atheroma is a substance of fat, calcium, cholesterol, particularly in the arterial wall. Therefore, arterial wall become very thick, hard. That's called arteriosclerosis. So that's the common disease in almost any aging elderly patient. Now, you probably heard about microangiopathy. Microangiopathy is a major problem in almost every disease we are talking about, particularly all neurodegenerative, other problems we are worrying about. Apparently is related to microangiopathy. And that it's a small vessel blockage. And that creates a certain hemolytic anemia and sometimes renal function in diabetic patient, and then thrombocytopenia in COVID virus infection. There's a new drug, eculizumab, that's a C5 and complement. This will deactivating some thrombosis. So that's a new drug helping. Now, we'll talk about more details about D-dimer whenever we think about a pulmonary emboli or thromboembolic disease. We measure the D-dimer. D-dimer is a fibrin degradation product. Measuring this D-dimer from blood test has shown 95% diagnostic sensitivity, but 50% specificity. So when this is abnormally high, that's useful, but what cause you can't tell. But it's a false positively increased by just old age and pregnancy, any vascular trauma, operation, and also chronic liver disease, rheumatoid arthritis, any kind of inflammation, and cancers. Therefore, it's a very non-specific. And also falsely negative if you sample very early or very late or insufficiently from blood. And the certain therapy, anticoagulation therapy using this kind of drug has shown false negative. So you cannot just rely on only one this kind of blood test because of very poor specificity. Now, atherosclerosis, arteriosclerosis has shown just a thickening of intima, the wall there, and therefore lumen become narrows. And the thrombosis, as I said, occurs on atherosclerotic, this plaque, and then a clinical question is always related to a rupture of this plaque. And the if there's some calcium accumulation, whole thing instabilized, but sometimes with a certain vascular injury or turbulent blood flow, that can rupture. And then that kind of clot travel to lung or brain, or heart, etc. Now, this, as you all know, the vascular lumen, endothelial cells are right there, and intima, media, adventitia. This, the wall vascular, is artery, venous, and the initial atheroma, just the fat, cholesterol accumulate here. And then certain our immune cells, macrophages, lymphocytes here. In macrophages, some papers, M1, M2. M1 is a classical, has a certain nitrogen oxide thing. So it's trying to protect a certain infection, bacteria, virus. M2 works in more likely wound healing or some kind of repair things. But sometimes M2 works oppositely to M1. And so this has been recently, sort of discussed a lot in cancer and immunology, some of the infection. So we'll hear more about this. So if diseases are progressed, unstable, this plaque can be ruptured. And then sometimes it's healed, but it's healed like this. So it's a continuous biological evolution. But the unstable atheroma can be a problem with two factors: increasing stress or weakening this capsule. If the atheroma has a less collagen synthesis or increasing degradation of collagen, or this kind of increase immune cells or decrease smooth muscle, or this capsule is thin or large lipid pool, or less stenotic lesion, then there's a higher chance for rupture. And certainly, if we have more cholesterol, that will have a large lipid pool as rupture. So these are the important factors. When we are getting old, after 50, you expect to see a lot of vascular diseases, including myocardial infarction, cerebral infarction, and some gangrenes and extremity arterial supply flow maybe narrow down, then the tissue does not receive enough oxygen and makes all this trouble, particularly in diabetes. And certain aortic aneurysm can be ruptured if the diameter is greater than 34 centimeters. And then, but this kind of atherosclerotic process seems to be very sort of steadily with a long time period, like 20, 30 years, slowly changing. So a certain dietary impact should be considered. Slowly changing endothelial or intimal wall changes slowly. And so on the images around the 40 years of age, we often see calcification from either hemorrhage, ulcerated thrombosis. We see a lot of calcification. So it's a certain fatty accumulation and some fibrous plaque, and then some ruptured hemorrhage, and then but stabilize, we see. But if it's unstable, eventually develop all this kind of major clinical problems. So again, arterial versus venous thrombosis show some different mechanism and some location, and then composition. I mentioned platelet is abundant in arterial thrombosis. Fibrin is, on the other hand, is abundant in venous thrombosis. Atherosclerotic plate rupture is a major mechanism of arterial thrombosis, but the we have so-called virus triad. That's a stasis. If you're not moving, particularly in cancer patients, lying down on the bed, or some venous wall, either trauma, whatever, and then certain underlying some hemoglobinopathy or any underlying vascular disease, combining all things makes this kind of venous thrombosis. So this often in the varicose vein in the many elderly people, but this arterial thrombosis is often from left heart. So atrial fibrillation, which is a very common 20-25% of general population, they can have a small clot, and then that clot can travel to our arterial system, makes a trouble. So in arterial thrombosis, make acute if that's involving coronary artery, that's acute coronary syndrome. If that clot is in the MCA, ACA, some cerebral arteries, that will make a ischemic stroke or TIA in early. And so sometimes limb claudication can be found. On the other hand, the venous thrombosis, we can have deep vein thrombosis that also eventually make a pulmonary embolism. So in the treatment, we use anti-platelet agent, certain aspirin, certain in early less than 4-6 hours, tissue plasminogen, factor drugs. But on venous side, we usually heparinize warfarin to basically stop further process of venous thromboembolic disease. So this thromboembolic disease has been reported to be increased worldwide. This may be even old data, but the reason is that people are living longer, so we have a lot more elderly aging group, and a lot of certain hypertensive problem, certain traumatic activity, many things are probably contributing together. But basically, more sort of a fatty meal contribute, I think, all this thromboembolic process. And certainly deep vein thrombosis is, I mentioned earlier, is basically related to trauma, certain operation, and certain stasis is a major factor. Therefore, if patient happen to have a stroke or pregnancy, cancer, they all stay lie on the bed without motion much, and that's a problem. And then certain fibrin-rich, that's a venous system. Now, we have tried to image this specific clinical problem with the anti-fibrin monoclonal antibody. That's called immunocentigraphy. I will show you more details. And so clinically, we need the differentiation of new blood clot, new deep vein thrombosis versus old deep vein thrombosis. CT, MR, ultrasound try to claim this kind of differentiation, but in practice, it's not easy. All the certainly clot make more organized, so the shape is a little different, but it's not easy. So because of platelet component more in new, if we use a radio labeled platelet, we can diagnose it here. And then certain TPA can almost melt down all the new clot if we have a patient within a day. So the separation of this new versus old is important clinically. And also using this heparin, warfarin, these things or TPA all has some side effects, as you can imagine, up to 10%. Therefore, correct diagnosis is important for the patient care. Again, this slide shows increasing all different thrombosis or pulmonary emboli. You see by age, increasing. So we have now more and more this elderly group in the world. So all these cases are increasing. As you see, it's a female, male, same way. All. So if you have a better diagnosis or better treatment in this thromboembolic disease, or if you have some way to prevent, you'll be rich and famous very fast. So I continue to emphasize our basic scientists to work on this a long-standing major clinical problem, that is a blood clot and infection. Okay, this respiratory infection often create this venous thrombosis or myocardial infarction. As you see here, after they discharge the patient with respiratory infection, pneumonia, other thing, and then patient develop this kind of blood clot. More and more. Why? We don't know yet clearly, but it's been known things. So there's some kind of mechanistic reason we have to continuously find out. And so this is COVID-19 thrombosis, certainly virus directly damage, platelet if the virus can penetrate bronchial wall. When you breathe, then the virus stay in the bronchial system. But how that penetrate the lung tissue is not known well clearly. And so that kind of things. But epidemiological study shows all this kind of thrombosis in patients with COVID-19. And certainly ST segment depression or elevation, there is also some suggesting myocardial infarction has been well reported. And so recently vaccine, particularly adenovirus, using adenovirus vaccines has shown thromboembolic disease. Why? And clinically, the clots are usually in the brain, hemorrhage things, or abdomen, and clinically low level of platelet cell fragment. But they also show some kind of thrombocytopenia. And they are thinking that this kind of heparin therapy bind to the protein, so-called protein factor 4. So apparently protein factor 4 is important, that this factor 4 destroy platelet. And so that's, but still not clear. So without heparin, how this triggering all this syndrome, nobody knows. So people are scared to receive a vaccine, but nothing is completely safe in the world. So we always have to balance risk versus benefit. And so that's the way we are living. And so the benefit is far greater than risk. That's why we are receiving all this vaccination. Now, hypercoagulability, just like any other disease, can be often related to genetic problem. So there's some antithrombin sort of protein C and S. Those are the important in clotting mechanism. So if someone who is born without or not enough this kind of antithrombin factor or protein C or S, then the person will possibly develop this thromboembolic problems. Okay, I will talk more details in the. Okay, so as you see here, if we have a certain vascular injury and then platelet accumulated and then attached to the wall, endothelial wall, and then that has to be activated okay, by all this this kind of glycoprotein things, and then they make a thrombosis. And so it's multifactorial, like everything else, and it involves every organ or tissue. Every organ has a vascular system, and so that can be blocked by some various factors. So modern lifestyle has to be blamed, apparently. There's a many for, sort of a delicious fat diet. A delicious diet is all basically poison to our health because of a high amount of sugar or fat. So this diagram shows evolution of thrombus initiating, starting with the platelet or fibrin, and then it's a thrombus formation here. But our body also another mechanism spontaneously sort of trying to solve by cell, by immune system, whatever. It's called fibrinolysis by plasmin. So we use this plasminogen for treating acute sort of 4-6 hour arterial thrombosis. And a lot of cytokines here, IL-6 particularly, there's a pro-inflammatory cytokine. This involved. So inhibition of things apparently has some effect to slow down or even prevent them. So the virus sort of a triad, again, this if a vascular wall is damaged or things, the platelet attached to endothelium here, and then all the fibrin, other things, macrophage, all the cells accumulating red cell, and then they form certain fibrin here, make a clot. So as you all know, there are many factors involving this coagulation. Intrinsic factors, extrinsic factors. Extrinsic factors basically when the tissue damage the tissue factor, that's factor 7A. That also the important in converting factor 10 to 10A things. And then basically, finally, prothrombin has to be converted to thrombin. And in this thrombin help to convert fibrinogen to fibrin. So thrombin is more like a protease. This is an enzyme sort of melting things. So sometimes prothrombin is helpful for treating patient, but this is also make this clot formation by producing fibrin. So again, platelet accumulation and tissue factors, and then this initiated here and amplified with other factors. And then the prothrombin make a thrombin. This thrombin help to produce fibrin and then clot things. And this a modern pathway, similar, but it's more emphasizing tissue factor, extrinsic factor, and then phospholipid play. And then thrombin, again, fibrin. This is a final, this important element are same. And again, there are certain inhibitory things for the treat to slow down or to stop certain this process. Antithrombin, certain tissue factor inhibition, and here there's a protein C or S here also working on this factor 8 to 8A conversion things. And also sometimes this factor 5 to factor A, this the protein C works on this one. So it's all different pathways. So platelet involves almost all kind of our body function. As you know here, besides the cardiovascular atherosclerotic process, even Alzheimer, Parkinson, all this is also microangiopathy. So that makes all cellular dysfunction. Although we know amyloid deposition or some dopamine, some dysfunction things, they also in the cancer metastasis, we see a lot of this embolic problem, particularly with the chemotherapy things. And then, it involves also immunoregulation, particularly infection, inflammation, and the certain this microbicidal proteins. I will talk more next week lecture. And the on the right side is recent information about all this involving platelet in growth factor and cytokine and even RNA, organelles, or mitochondria, all the things. So a platelet is so important in our body system. And the again, glycoprotein 1 and 5 apparently important in the process of thrombosis. So this C-rectin, protein receptor is also working in this thrombosis growth. And so more and more this kind of some certain factor things have been discovered. And so it's obviously multifactorial. So that means it's not easy to completely get rid of this clot by just one drug, things like that. So in cancer, okay, it's activated platelet make angiogenesis. So you can see a lot of vascular, certain whole growth factors here, and then certain inflammatory cytokine things. And so these are all fibroblasts and some endothelial cells proliferating, and this adipose tissue originated stromal cells. All these things contribute to angiogenesis. So this makes a tumor growth and metastasis. So as I said earlier, the thrombin is like a protease. So it melt membrane basement, and then sometimes it bind to the thrombomodulin. That's an anticoagulant, and then activate the protein C. So this is somewhat confusing because protein C and S contribute in clotting formation, but this also inactivate factor 5, 8. So like many other things, we have sort of two different functions of the same thing. And so this has to be certain balanced situation over some certain amount in optimal function things. And then the problem is certain patients seems to have a mutation in this kind of genes. And so that's creating certain genetic sort of this thromboembolic process. So inflammation, again, is causing all the things, particularly shedding of thrombomodulin protein, and that promote thrombosis. So tissue plasminogen antibody, excuse me, it's a works of plasmin here. And so this will degrade the fibrin things. So in very acute sort of a blood clot within 4-6 hours, sometimes 24 hours, we can melt down arterial clot using this plasmin or TPA. And it's been found that this deep vein thrombosis or tumor emboli occurred in patients with depressed or less amount of TPA stores. Many factors contributing decreased synthesis of TPA. There are obesity, certain lazy lifestyle, smoking, particularly birth control, estrogen, apparently has been blamed things. But depending on the amount of this, very, so menopausal ladies are worried about taking any, estrogens, but most experts still recommend very low dose, lowest dose estrogen to have a much more benefit. Estrogen also involved in brain function. So memory loss and certain particularly bone weakness, so many advantages. And certain thromboembolic problem or uterine cancer risk is there, but much less than large amount of benefit. So again, plasmin or plasminogen help, and treating coagulation process. There's a lot of factors involved. The drug or alteplase, this recombinant human tissue plasminogen activator. That's sort of a serine protease. Protease is one of a major, enzyme or a gene for the mechanism of metastasis. So and also even Alzheimer's, very early, tau or some amyloid, those deposition often relate to this. There are many types of proteins of this protease. Again, this is a way to treat a very acute early arterial thrombosis. And some patients have elevated this plasminogen activator inhibitor 1, and that's with the inflammation and then some obesity, hyperhomocystinemia, that kind of thing. So if this inhibitor 1 is elevated, then the patient will have a higher chance of thromboembolic disease. So again, inflammation, obesity, and some congenitally this hyperhomocysteine. So we can check homocysteine level in the blood. So those high risk for thromboembolic disease. And again, the Viro, German pathologist, proposed triad. That's this alteration in the blood flow, so stasis, and that's a major, and vascular damage, and then certain blood property, like hemoglobin, some red cell abnormality. And so if there's always some thrombogenic factor and protective, it has to balance. If there's a breakdown, this balance, then thrombosis occur. This just like any other disease process, there is some homeostasis of many factors, balanced. So if the balance cannot be maintained, then there is a thromboembolic process in the body system. So again, immobility, stasis is a major. Okay, and vascular wall changes by trauma, other things, that's a loss of antithrombotic mechanism here. And then certain clotting factor, congenitally, other things, elevation. These are all three combining. But again, this is triggering inflammation, and that produce acute or chronic thromboembolic disease. So the factors here again, polycythemia is one of known, in addition to stasis, immobility. The endothelial damage is also related to smoking. So many smokers are worried about only lung cancer, but actually smoking has known to change the our gene, so it's triggering gene mutation, and then practically this kind of endothelial dysfunction. So that's now you go to hospital, almost everybody end up having IV or cast, but those are all contributing endothelial damage. Surgeries, of course. So we all have a high risk of thromboembolic disease. That's why it's so common, increasing, and in the problem. And in the blood property problem, Okay, congenital, factor 5, as I mentioned, protein C and S deficiency, certain prothrombin factor, the acquired one, cancer, chemotherapy, or obesity, or things. So many cancer patients are died of either blood clot or infection, not by the cancer. Chemotherapy, because the chemotherapy damaged the vascular wall. And then also the chemotherapy knocked down good bacteria in our gut microbiome. So then the bad, gram-negative bacilli like E. coli, Klebsiella, came out from the gut and goes to the liver, lung. That's so-called superbacteria, which are not sensitive to conventional antibiotics. So that's all immunosuppressive patient died of such a mutated gram-negative bacteria. But they also have all kind of blood clot problem. Okay, venous thrombosis or pulmonary emboli or cardiac or stroke, etc. So again, blood flow, arterial, or a certain particularly this at the bifurcation in the brain. That's we call anterior communicating. That's anterior cerebral artery, middle cerebral, that junctional area. That area can have aneurysm, and then also that area, if that area damaged, that's easily because the flow is turbulent in that sort of acute junction. Venous or immobility, certain hypoxia, etc., makes trouble. And the endothelial dysfunction by hypoxia or distension or certain, many factors, as I mentioned. And then ruptured plaque or endothelium induce a lot of factors contributing all this blood clot. So there's a relative risk. Oral contraceptive is a 4, but other factors, these are all contributing related to a thromboembolic process. We have a lot here. So there's a risk. Inflammation is activating endothelial cells. So that enhances tissue factor, that's a problem. Reduce tissue macrophages, etc. Endothelial adhesion molecule will be increased in inflammation. So inflammation, cause every disease, particularly this blood clot. So there's certain particles like we have a lot of dust in major cities, particularly the microparticles from China are the coal, sort of burning places. Those become sort of pro-coagulant. It showed that a certain activation of tissue, sort of extrinsic factor, tissue factor, that's triggering, that's a coagulation process, most important. So eventually, the fibrin and then thrombosis. That's why it's important to live in clean air without mask. So if any patient becomes septic, and the patient ends up developing disseminated intravascular thrombosis or intravascular coagulation and died. That's a very common problem, sepsis, particularly in the fecal bacteria. They all develop septic shock and then develop multi-organ dysfunction due to disseminated intravascular thrombosis or coagulation. And this HMGB gene, that's also contributing, together, as you see on this one, is studying tissue factor and then similar monocyte and certainly necrosis factor, cytokine, but it hit the platelet and then certain endothelial dysfunction, all things, and some this oxygen-free red color, all things. Anyway, this gene is now studying more and more. This contributes mainly for this disseminated intravascular thrombosis. So this is one of the major clinical problems. Microangiopathy is the heart and the brain, every place. The multi-organ failure. So that's what's it? That's a high mobility group box. How can I move? Okay. That's a high mobility group box 1. This right here. And there's inflammation and some cytokine, all things. This gene hit the intestinal tract or endothelial cell or whatever. So the patient developed disseminated intravascular thrombosis. And so when we receive vaccine and antibody production related to coronavirus, they activate, this antibody also activate platelet. So some may develop thrombosis. Particularly adenovirus vaccine directly damage platelet, but messenger RNA vaccine also possibly produces thrombosis because of antibody activating platelet. So it's all now is a potential sort of a mechanistic explanation, but we need more data. But again, the vaccine, in fact, the platelet triggering the whatever thing. So clinically thrombocytopenia, hemorrhage, blood clot, etc. This is a serious. This vaccine may make an autoimmune sort of response against platelet or effect of T cell, CDA lysis. So in the tumor again, we have this kind of factor, multi-factor, and the microparticles are contribute coagulation. And some with this factor maybe dissolve clot, but some is more clot activate. And in particular, tumor sickness also a lot of tissue factor, thrombin, so make a clot. So some is okay, this is well balanced. Some predominantly clot, some resolve bleeding, all the things. So on the image, you can see easily clot in the inferior vena cava you track down, you particularly if patient has a renal cell, it goes to the renal vein thrombosis, the thrombosis, the tumor thrombose, move to the inferior vena cava, go to the lung. And so if there's any blockage of the vascular system by the tumor emboli, but you will see thrombosis very soon. And diabetic angiopathy is also a continuous problem. It's a microangiopathy. Insulin resistant, impaired insulin secretion causes diabetes, and that will show microvascular dysfunction. But this occurs in every tissue, particularly retina, things advanced, makes retinopathy and nephropathy, and even brain depression, cognitive impairment, etc. So in hypoglycemia, you expect microvascular disease in particularly brain, heart, eye, kidneys, those are the major. These are all due to microangiopathy. And so that's a serious problem, complication. Diabetes itself is not a problem, but this complication killed the patient. So in the retina, oh, it's so complicated, but you can see the capillaries. Capillaries and neurons here transmit, it's a lot of nutrients in the glucose, glutamate, and then lactate as well. So certain astrocytes receive the glucose metabolism produce lactate, too much, too little, or problem. And so all this energy produced here. So if this capillary become blocked, occlusion here, then you'll see some leakage, some blood spot on our fundoscopic exam, and is a wall endothelial wall damaged, some red cells changing, some platelet accumulated, that kind of things we see on endoscopy. And then the patient can be blind. So again, this endothelial damage, inflammatory or cytokine, other things are combining together. You know, there's always both sides impairment or some repairment, certain. And so how much? That's sometimes. So it's a small vessel blockage cause all problems. So how that happen? Well, if there's endothelial damage, there's a NF-kappa B. Actually, this is a gene for inflammation or cancer. Okay, nitrogen oxide production decrease. That's why it's oxygen deprivation. And on the other hand, the reactive oxygen species increase. It's toxic. That's what there's certain harmful metabolite increase, and the increase the lipid peroxidation product increase, and impair the endothelial relaxation. Certainly macrophage, as I mentioned earlier, increase all the cytokine IL-6, that's a pro-inflammatory. And then the all important thing is the protein kinase C is increased. So that's why it's a clotting. And then the endothelial vascular wall, but also muscle cell, smooth muscle also proliferate, thicken, so lumen become narrow. And then there's a lot of matrix, like chondroitin, sulfate proteoglycans, those are accumulated, and elastin degradation, matrix degradation called elastin increase. And certain monoenzymatic collagen glycation also increase. Okay, and so this glycation, with the aging, just aging, you end up having this kind of process. NF kappa B is activating, so that could be inflammation things, and the endothelial damage. So when you are getting old, your eyesight, everything, dry eyes, everything. There's arterial stiffness, endothelial dysfunction, these things happen. And certainly other, there's macrophage, immune cells, dysfunctions also contribute. So vascular stiffness is, if you are getting old, muscle stiffness is the major things you notice, particularly thigh muscle is first, but all vascular, everything it becomes stiff, elasticity decrease. And so that known this rage, whatever, this pathway or this ligand thing, people try to inhibit all this signal thing to relax the vessels or muscles, but I think this may give a temporary something, but I doubt this will make a permanent solution. You probably, I mentioned briefly that the atrial fibrillation is a very common problem, about 20%, 25% in general population. As you know, in the heart electrical pathway, through the node, sinus node in the atrium, and then the atrial ventricular node in the aortic or mitral valve system. It's triggering all the electrical triggering for the cardiac rhythm. So it's normal sinus rhythm here. But as you see, the rhythm is so fast, that's called atrial fibrillation. QRS complex so frequent here. So this usually occur in the night and more female. So it's a lot of stress, other things may be related, but no one knows exactly why this happened. But the clinical problem is resolved, but they occur again, resolve again. And so cardiologists monitor this kind, but when they monitor, they don't see much because it occurs so often in the night. In the daytime, when the cardiologists try to check, it doesn't show much things. But the patient laying down on the bed in the night and they feel very, pumping fast, and the pulse are very rapid things. Almost 10% of elderly old people. And then here is very low, but as they say it's a 30 seconds, but some minutes to several minutes. And spontaneous terminated within a week, but some goes on then. And then some is a permanent thing, so that's a problem. And the left atrial appendage, there is some kind of a little extra tissue in the left atrium. There can be 2 lobes, it can be 3 lobes, 1 lobe, more than 3 lobes here. On our FDG PET scan, often you see hotspot in the left atrium because the left atrium with this lobe more likely move more than other walls. So we can see sometimes a very hotspot. Clinical problem is that if we have more this lobes, then there's a higher chance for embolization. This blood clot can move to lung or brain, that's the thing. So, well, sorry, this is blood from the paper, but there are 4 different types of the kind of appendage, left atrial appendage. Cauliflower type, and some windsock, this is a cactus type, and this a chicken wing type things. The fluoroscope show, and then this CTA show this kind of tissue with different configuration. And that can contribute that thromboembolic disease. So cardiac problem is one thing for this thrombosis. Now we see many times incidental this inferior vena, this aorta, abdominal aorta, inferior vena. You can see large filling defect, that's a blood clot. Okay, and then with this one, you can put the filter after you interventional radiologist put and cleaned, and then put the filter. Okay, and we also have clinically some problems of pelvic venous system. Pelvic venous system is related to physiologic menstruation, ovulation, and certain pelvic inflammatory disease can cause pelvic pain. Ladies often have vague pain in the pelvis, and certainly besides this physiologic ovulation, menstruation, most commonly PID, the cause is very difficult to pinpoint down. But there are many causes like cystic disease, endometriosis, that's common in Asian, Korean. Fibroid is every ladies have fibroid. And certain malignancy, some prolapse of uterus and or bladder, cystitis, certain calculus, very severe pain. The gastrointestinal, like inflammatory colitis, Crohn's disease, diverticulitis in American ladies, and irritable bowel syndrome, very common, sensitive ladies, certainly malignant. And then also some kind of lumbar lower disc, sacral canal stenosis, spondylolisthesis, that's also rarely cause this kind of pelvic pain. And one of pain is called pelvic congestion syndrome. And that pain usually lasts more than 6 months. It's not cyclic. It's and often related to dilatation of sexual, this gonadal or pelvic venous system. This often occurred in the premenopausal, but the multiparous ladies. So after delivery, many babies, all this pelvic venous system become either compressed or somewhat dilated, and so blood flow is maybe slow down, or some reason they have occlusion. So that can cause pelvic pain. That's called pelvic congestion syndrome. So as you know, in the left ovarian vein is connected directly into left renal vein. Right side ovarian vein directly connected to this inferior vena cava, this one. So it's it's important, this things, because when there is a blockade draining, you have to look for left side renal vein, right side inferior vena cava. So on the renal vein, you can compromise. This is superior renal vein is just underneath superior mandatory artery. Okay, and so it's a pancreatic tumor, other things are blocking here, then also maybe compress the left renal vein, and then you have obstruction of left ovarian vein in ladies or in male testicular vein. Then you have a pelvic congestion syndrome, pelvic pain here. So these kind of things, dilated left ovarian vein connected to left renal vein. So here, so all clear. So the mechanism is just a pelvic venous incompetence. venous system has a certain valves. When you're getting old, the things that valve function is decreased. And some say it's a hormonal factors. And there are two very known sort of obstructive disease they call May-Turner syndrome, nutcracker syndrome, say, of the pelvic varicose veins. And the May-Turner syndrome, we don't know exact instance, and usually left side, deep venous system contribute in about 1/3 of things. And the overlying, right iliac artery may lead to venous wall damage or partial obstruction. That's a postulation, nobody knows. So these kind of things, blockage. And blockage of the variant or atherosclerosis veins is connected to left renal vein. And the nutcracker is a left side renal vein, compression. So it's when we have this kind of thing, certainly surgical intervention is most likely. So the before we have breakdown, I want to finish up the certain common clinical another problem. But this is a pelvic congestion syndrome. The usually ultrasound or this contrast study showed the larger than 5 millimeter sort of a tubular structure of the obstructing left ovarian or testicular venous system. And this iliac genital veins dilatation, and they make a reflux using a Valsalva maneuver. So that's what we diagnose. And then certainly surgical intervention. Now, erectile dysfunction is a common now problem in many 20 million American men. We are getting more and more this elderly people, and this is old data, but the 300 million men worldwide complain erectile dysfunction. So even 5% at age 40, young age. But once you have 60, 25, 70, 35, 80 is almost more than half. So certainly erection is related to parasympathetic relaxation of sinusoidal smooth muscle and dilatation of helicine arterioles. And there's an expansion of lacunar spaces in the penile structure by entrapping blood with the compressing venules. So they measure this kind of things. Erection, of course, almost 3 times more blood flow. So why is importance? Because vasculogeny, like this penile certain vascular obstruction is about half, diabetic 1/3, but psychogenic is quite a lot, psychogenic, neurogenic, it's probably maybe quarter. Certainly testosterone deficiency. So even there's a structure, structures or venous system, arterial system, okay, but if the testosterone is lower than normal range, it's not functioning. And certainly you have to check about thyroid, you have to check about pituitary hormone. It's all connected. Besides all this, malignant trauma is more likely exception. So we see often calcification in the certain penile arterial system. Calcification, as I said earlier, it's certain atherosclerotic process, ruptured thrombi, and then certain calcium fibrin deposit. It's a blockage. And this is a super selected pelvic arterial things. And it's a pudendal artery, this is scrotal artery branch, this common penile, and this is a dorsal penile version. And there's some leaking here, something. So this penile, dorsal, ventral, and some this thing. So if there's a blockage thing, so you can easily detect it. So unlike the other normal, here is okay, but the down here is blocked. So surgical, certain revascularization process should work if patient has a particularly trauma injury, and then a certain pharmaceutical treatment has been tried, but arterial reconstruction is best if there is a vascular origin. Okay, so we'll have about a 10-minute break, and then I'll finish up with deep vein thrombosis and pulmonary emboli. Okay, so we'll come back in 10 minutes. We'll continue to discuss about the thromboembolic disease. As I mentioned earlier, deep vein thrombosis is a venous clot. So in the venous system, there is a valve there. So when the flow goes through, this valve prevents sort of a backflow, regurgitation, so that there is normally some turbulence around this valve. If flow is slow, if the flow is fast, it go up quickly. But if slow, little bit, then they stagnated here. That can cause some blood clot. As I mentioned, stasis is a major factor of Virrow's triad. And certainly intrinsic factor and extrinsic tissue factor together will make a blood clot. Certainly prostacyclin synthesis is decreased in those processes. So again, stasis is the most important. As I mentioned again and again, all kind of things contribute to stasis. And then the infection, obviously, makes these changes of protein, particularly C-reactive protein, fibrinogen, that kind of thing. Certainly inflammation. The cytokine IL-6 expression. Certainly myocarditis, any inflammation contribute, thrombosis, and so on. All these factors I just mentioned together define thrombosis. So we have some clinical sort of routine test, and then international normal ratio. That's a prothrombin time ratio. Prothrombin time is basically rate intrinsic factor, partial prothrombin time, extrinsic factor. But this PT international normal ratio is normally 0.8 to about less than 1. Okay, if this is elevated slightly, that's a hypo. So normal so coagulate per peptone show increase, but it's a marked increase, that's a hypocoagulable, hypo. And the D dimer obviously very continuous increase, and the platelet count decrease, the marked decrease. If there's not much platelet, there's no clot, so it's decreased. So fibrinogen is a marked increase in clotting. So the reaction time, we use a thromboelastography sort of chart and show the reaction time is increased. That's a hypocoagulable state. So amplitude also is decreased. So we're looking this one, you can separate normal versus a very hypocoagulable, clotting, bleeding separate. So this is the chart for that thromboelastography and reaction time from here to slowly. So they describe erection time, and then normally 5 to 10 minutes, that's a normal range. So the most pulmonary emboli are coming from blood clot in the leg. So leg clot travel, and then stuck in the lung capillary. Yeah, so about 90%. All clot in the lung comes from venous blockage in the lower legs. Most commonly, this thigh, is a femoral vein blockage or iliac vein. Not is a peripheral lower down here. So again, a thromboembolic process, you have a balance between clot and then bleeding. So activation of coagulation by inflammatory cytokine, all this necrosis factor, monocyte, tissue, as mentioned, protein C, etc. Coagulation, but also endothelial damage. This cytokine involved, and the release of this factor. So in acute pulmonary emboli, if we don't treat the emboli completely, then it eventually makes some kind of vascular remodeling, and that is one of the cause of chronic pulmonary hypertension, and that's obviously current clinical problem in chronic sort of vascular remodeling. So treatment or prevention of this venous thrombosis, we usually use heparin. Low molecular heparin is now mostly used, and vitamin K antagonist, and certainly a filter, mechanical filter, or a certain sort of compression dilated the venous system by stocking and certain. So again, normally flows go here, valvular system prevent backflow, but if the slow is a flow, a lot of stagnation here and causing a varicose vein and blood clot. So this ultrasound, the femoral vein, you can see some echogenic clots here. This artery, femoral artery vein runs together. And certainly this Doppler can show color. So it's a blockage here. If there's a flow, you can see here. There's a blockage here. Popliteal is behind the knee. Again, it's chronic deep vein thrombosis, some clots here. Ultrasound certainly is very helpful, but depending on operator's experience position. And you can only show some clot, blockage, but you can't tell whether it's acute, chronic, that kind of thing. as I mentioned earlier. Okay. This is a side, this knee and the lower leg. When you see it, this convex, this is a superficial gray saphenous vein. Middle right here, that's a deep femoral vein, popliteal, and the lower down, you have three, anterior, posterior, tibial, and peroneal. That's peroneal. So here you have a superficial gray saphenous vein. You don't see this kind of, it's a lot of collaterals here, so blockage of the lower down popliteal things, and this all this collaterals. So iliac vein here is external common iliac and inferior vena cava. You don't see filling of left common iliac and external. Internal iliac is has an anterior posterior branches supply buttocks or internal pelvis. So it's a block. Once the block down here is a continuous propaganda, and then you collaterals again. The ovarian testicular vein will be dilated if there's a blockage. This is on the right side, the common iliac venous system blockage. So on the contrasted CT-MR, you saw filling defect, large filling defect, you can see easily. And yeah, this kind of things are filling. So, and the collaterals will show on this subcutaneous tissue or things. So, and this is aorta, abdominal aorta, inferior vena cava, large thrombosis. And so this is a right pulmonary artery. You have a filling defect. You have a small filling defect, and then here certain inferior vena cava, and certain iliac artery vein blockage here. And the inguinal is a filling defect here. So, and the vascular plaque, as I mentioned, inflammation is shown by FDG. And then a microcalcification, certainly sodium fluoride, directly, this is a fluoride directly exchange with the hydroxy appetite in the sort of bone or this kind of calcium. And so calcification will show certainly on CT that indicating vascular stiffness and some plaque burden. And this plaque rupture is important. So how is inflammation? As I said earlier, so much necrotic, thin fibrous cap, calcification, hemorrhage, neoangiogenic hypoxia, those are contributing factor for rupturing vascular plaque. And you can see calcification in the anterior descending coronary artery and the posterior here and right side here. And calcification outline abdominal or thoracic aorta here. And then sodium fluoride, the path obviously show the calcification because of the fluoride direct exchange with oxygen, but the bone scan agent, MDP phosphate component directly, not directly, is attached to those calcification. The mechanism is still unclear, but it's been shown to have a certain relationship with the uptake of fluoride or phosphate with certain aorta, certain calcification amount. And well, if we treat the patient earlier, less than a week, and then there is some thrombolysis, And so how much? And then, as I said, less than 1 day by certain TPA is most effective. But after 1 day, you may help some, but not completely. So in the past years, we have technician labeled a lot of agents to demonstrate venous anatomy and obstruction. The technician, particularly MAA or red cell. And we prefer to use this first if we cannulate the venous veins, either lower leg, ankle, foot vein, then we trace the flow. And then this will all eventually trap in the lung capillary. So we have a lung perfusion scan. If we cannot cannulate the foot vein, then we have a whole body technician red blood cells. Then you can only evaluate large vessel, like a abdominal aorta or inferior vena cava or iliac, but the small veins in the lower leg, upper extremity is not easy. The femoral veins is okay, it's a large vein. But we like to emphasize more specific imaging of thrombus by utilizing anti-fibrin or anti-platelet, particularly arterial pulmonary artery anti-platelet, and this one. So we can diagnose very early new blood clot. This is a usually venous system. So if we have this one, we can have a flow study to see to evaluate the flow pattern and obstruction. And then usually after 1 hour wait, then continuous accumulation indicating accumulation of platelet or fibrin. So that has a tremendous advantage. Well, unfortunately, we had the technical labeled the peptide P820, which was very useful to detect the venous obstruction and diagnosis acute pulmonary embolism or acute thrombosis. But before FDA approved that agent, and small company, Diatec, was bankrupted. So we don't have this. So somebody has to continuously work on this one. Technician labeled the platelet, antibody, or peptide, that kind of things. So in the venous system, certainly venogram, we call radionuclide veno, we can have a dynamic pull and an antibody against the platelet, fibrin show thrombosis, and then, so here, in the upper extremity, we inject into antecubital vein. This is a cephalic and bacilli. Okay, this is every second or 2 seconds. And then you can see subclavian vein, usually it comes down to obliquely down, and then down into the right heart. And this is a brachiocephalic level. But you can see collaterals rising from the left subclavian vein above, and then this is probably a left side superior vena cava. So obstruction is right at this left side proximal subclavian vein. And so there is a hemodynamically significant obstruction, so that we see collaterals. So you can see all the collaterals here. Yeah. So is there a new blood clot, old clot? You can't tell. This is just obstruction. Now here, this is a marker. This is a, here you can say inferior vena cava, iliac, right side, iliac, femoral, left side here. There's some kind of activity connected. And then this is usually placed in the symphysis pubis, things like that. So usually we should have this kind of femoral popliteal. But if there's an obstruction, you may see some, this inner side is a superficial saphenous vein. So here, so you can see on the left side, this marker on the knee, medial knee. So this way, there's a superficial saphenous. This is a femoral popliteal down here, and this is some obstruction on the left side. Okay, here, superior vena cava, inferior vena cava, right iliac, right femora. You can see all these are very old. These are collaterals. There's obstruction, no flow through the iliac chain. It's all collateral activity here. Down here, this is a femoral popliteal and tibial. Obstruction may be here. There's all collaterals in the left thigh, knee area. And then this is a red cell study. It's so much background activity is not easy. It's iliac, so any asymmetry you have to watch. Okay, and then here popliteal, and this is some tibial and peroneal. Here, this is anything. So here you can see asymmetry is all collaterals left side, the red cell. So that's, yeah, here you can see the right side, but there's obstruction here, collateral, connecting to the opposite, and a lot of collaterals in the upper thigh. Or red cell study also show this iliac popliteal, but these are all just collaterals. So, and the imaging, again, it's all so many peptide, fibrin, even D-dimer antibody, try. All this is what I was talking about. This technician, Epsitide. This FDA approved, but right after that, the Diatech, small company, was bankrupted. So it's no longer available clinically. It's so bad. And then this annexin 5 is related to phosphatidylserine setting, so apoptosis. If we evaluate apoptosis, technician, this one is good. Again, to evaluate vascular plaque, a lot of agent has for inflammatory cells, FTG, chronic inflammation, hypoxic cell, myosinidazole, hypoxic. And then there's some macrophage things has some receptor of somatostatin, and that can be imaged with dotatate, okay? And then certainly angiogenetic things can be evaluated, RGD, some mineralization calcium, we use sodium fluoride. So there are many things we can use. Now, again, it's an old slide, but the indium is a carotid thrombosis image accumulation. It's a positive finding rather than negative one. So this is a very acute blood clot that can be treated with TPA and then gone. So here is this bypass graft, and in the platelet shows all this clot inside the graft. That has acute thrombosis. Okay, there's a tibia. This is a tibia, anterior tibial, peroneal usually lateral here, and the platelet show accumulation of blood clot. Certainly, when we inject, it can have a dynamic. Then you know exactly what venous system, where exactly obstructing. But this delayed image shows just the clot formation of the acute thrombosis. Okay, the fibrin also show, but the fibrin is more venous system. As I mentioned earlier, this kind of popliteal is a blockage. There's a venous thrombosis. Okay, fibrin again. Yes. sort of anti-fibrin also show here. Somehow it's, this is 20, 30 years ago, these things, but somehow nobody continued this kind of new agent, unfortunately. It's all just on news papers. After that, it stopped. And this is another thrombosis agent of femoral. So all this publication. And as I mentioned, I was an investigator, first investigator. I enjoyed this one because I can evaluate dynamic by injection and then blockage ejected, and then new old I can separate, so of delay damage. So this was so useful. I wish I can have it again. There's a anti-D-dimer, also representing acute blood clot, and then show here accumulation here. So now in the peripheral arterial system, we have a particulate labeled technetium particle, non-part diffusible, certain. This thallium chloride, we use this one for myocardium. It's a perfusion imaging, okay? And so it's a non-gas, so we can, so this is a peripheral arterial disease, and in resting and some stimulation show some difference, and then if there's any asymmetry and certain peripheral vascular disease, it shows less activity. So this has been, that's also old. Now, finally, we can talk about pulmonary emboli. Again, pulmonary emboli is a still serious problem. There's at least 200,000 deaths per year, increasing worldwide because of many regions I mentioned for thromboembolic disease. And the problem is that we still have a difficulty to diagnose of significant pulmonary emboli. And after we use high resolution CT, particularly multi-detector system and fast imaging, particularly after we use 64 slices or 128 slices, and we at the MD Anderson we slicing 0.624 millimeter of the lung to look for tiny metastasis from lung cancer, renal cell cancer, etc. Such a tiny high-resolution CT show a filling defect in small peripheral branches of pulmonary arterial system in almost every cases. Now, so we had a hard time to report. If we call pulmonary emboli, we should do that. But then clinicians are obliged to treat patients. But many patients had the surgery, chemo, etc. So they are clinicians worried about bleeding after heparin, etc. And overdiagnosing pulmonary emboli was a major problem. But lawyers enjoy of having such a case because when the patient dies, autopsy show all massive pulmonary emboli. And then they blame clinicians that they didn't treat pulmonary emboli in early. So it was hard, and then hard to still difficult to handle such a case. Nobody knows what we have to do. So because they were all asymptomatic, no patient. Now, you can divide the central large pulmonary emboli versus peripheral pulmonary emboli. And chest pain, shortness of breath are major clinical sort of a complaint. And then normal chest X-ray is the most common and most helpful. But in cancer patient or many other patients, they have all underlying COPD or some kind of old lung disease, etc. That's why it's difficult to make a correct diagnosis. So having a lung function test, other things all together, now D-dimer. So contrast CT is a first line. If there's no blood clot, then if a patient doesn't have a symptom, that's a stop. But if it has some symptom, they still try to use a nuclear medicine lung scan. Okay. And certainly, pulmonary emboli does not deliver any oxygen. So clinicians often misunderstand that when the PO2 is down, they immediately think of a pulmonary emboli. But that's a bad thinking. When the PO2 is down, that's more likely bronchial disease, because oxygen to the lungs mostly supplied through bronchial system, not the pulmonary artery. Bronchial artery contribute about 5% of oxygen supply. So that's the one thing you have to know. And then we are still try to use VQ mismatched abnormality because when the bronchial artery is obstructing, then our body always trying to maintain VQ ratio. So when the V is down and Q is supposed to be down, so we have a matched abnormality for most bronchial disease or lung disease. But however, when the pulmonary artery is blocked, then only in acute, hyperacute situation may show matched abnormality. There is an immediate vasoconstriction, the bronchial constriction. So, but practically, when you see patient in the emergency room, it's already several hours past. So the VQ mismatch is expected for pulmonary emboli. But I've had several cases of matched abnormality in very hyperacute pulmonary emboli. So that's the only exceptional. So some people try to use just chest X-ray. If chest X-ray normal, then they do only perfusion study. And if perfusion study is normal, stop for heparin treatment. But if perfusion study shows a more than 2 segmental defect, then that's called high probability. That certainly makes sense together with D-dimer study. So many other lung disease, bronchial disease, all show some hypoxia indirectly, all things, but we are dealing with probability. High probability is more than 2 VQ mismatched. High means greater than 80%. Now, if you don't see anything, I call very low probability. Very low means less than 1%. I never call normal. In nuclear medicine, you should not use normal study because we are basically evaluating functional, not anatomical study. So microemboli or fat emboli, you cannot diagnose. So when you say normal study, that mislead. So very low probability, less than, when you don't see anything. Now, most paper report that majority of our lung scan, VQ lung scan, majority means 80%, showed intermediate or indeterminate pattern. So I never use terminology, intermediate or indeterminate. That's a useless study, useless. So PIAPET 1, 2, all that's useless in my view, because they all give more likely intermediate, indeterminate probability. So after I look at the scan, I go by clinical likelihood. So when you see a certain intermediate pattern, then you look at a clinical record or a patient. If a patient has a high risk, high likelihood because of certain underlying factors. As I mentioned, that's stasis, long sort of immobilization or chemotherapy or any vascular accident, trauma, all those are risk factors. Then I try to make a little bit overcalling. On the other hand, if a patient doesn't have such a thing, then I try to make undercalling. And then sometimes I make overcalling for patients who were on the internist. Internists like to give a drug, heparin, but I often make undercalling for patients from surgery. Surgeons don't like heparination because of possible bleeding complication. So that kind of, so high, low, that's it. Based on imaging finding and clinical judgment. That was more helpful than reporting intermediate, indeterminate, etc. So diagnosis, D-dimer, and angiogram, and then pulmonary. So angiogram is like a screening, fast, but it's oversensitive study. And then angio cannot separate acute blood clot from old clot. So it's a blood clot here, okay, is right upper, right lower, this kind of blood clot. And here you can see pulmonary, main pulmonary artery, here is embolus. Okay. But problem is kind of small branchy, okay? And then here, small clot here, small. Is this significant? Nobody knows. And the small pulmonary emboli has been a major issue. What do we have to do? Because the small one, the body trying to get rid of that, particularly in pulmonary artery, high blood flow breakdown, clot smaller, and then finally macrophages sort of eat them, macrophages, phagocytize. So they may have initially little, maybe some heaviness of chest, but as long as you supply oxygen, no problem, clinically. So it's hard to draw the line. And the overdiagnosis on all this has been well published. And so no one exactly knows what we have to do, okay? And so still, we need still more specific imaging. As I said, current VQ imaging is indirect, it's not specific. So particularly with the COVID, as I said, all things, our current, and then certainly spexity is better to localize precisely and then detect very smaller things, but we need a more specific agent, as I said again. So just a high probability, very low, that's it. Nothing else in between. And then there are many conditions for BQ mismatch. So always think about intrinsic as well as extrinsic compression of pulmonary arterial segment. Okay, so these are the intrinsic, but bronchial carcinoma extrinsic. So it's a compressing actually bronchial segment, but as I said, body is trying to maintain VQ ratio. So when the V is down, Q is down. Okay, high adenopathy, all this, the same thing, extrinsic compression. And also this one, occasionally you see congenital absence of pulmonary artery. Then there's no perfusion, but bronchial segment seems intact, therefore classical VQ mismatched. Yeah, certain Swayze syndrome, some get post-radiation. And so these are all extrinsically bronchial disease, and for certain vasculitis interest disease. So always consider a intrinsic as well as extrinsic obstruction of pulmonary arterial segment. And as I say, high probability multiple bilateral. So if you have a unilateral large perfusion defect, that's unlikely pulmonary emboli. So what else? Then you consider either bronchial, extrinsic bronchial lesion like lung cancer, etc., or pulmonary congenital hypoaplasia. Okay, D-dimer fibrin degradation product. So it's a highly sensitive but non-specific. Okay, that's the key thing. So, but positive increasing level is useful. And all the things. Okay, but false positive is a problem. Aging, pregnancy, other things as I mentioned. And as I said, in my old days, 30 years ago, it was so useful with this kind of technetium labeled the platelet, D-dimer, show directly a forming or acute pulmonary emboli. Okay, so ventilation, we use xenon study, but krypton 81 if you have a cyclotron, or certain technetium gas or other things. Aerosol DTPA. Now, aerosol DTPA, if patient using nebulizer, breathe in and out properly, that's a very useful because the images are very comparable to perfusion imaging. So you can easily mismatch in all lung segments. Now, as you know, right lung has a 10 segment, left lung has an 8 segment. So it's all overlying. So without multiple static images or SPEC, you cannot pinpoint the exact segment. So try to interpret, but pulmonary emboli is also gravitated. So it occurs more in the dependent, so lower lobe. So in the lower lobe, posterior basal segment is most common. And the superior segment of lower lobe is second most common. So rarely in the apex things of pulmonary emboli. Okay, so in the study of the perfusion, when you inject, you have to lay down patient and then inject. So it distributed uniformly. But when you image, it's sort of standing up position to minimize the diaphragm motion, etc. And that's technical aspect. And so, now is the MAA synthetic particle, usually 20 to 40 micron. MAA, natural protein blood component has a 10 to 100 micron. The lung capillary is a 7 micron, 7. Lung sort of a pre-terminal arterial is about 10 to 15 micron. So when you give 5 millicurie technetium MAA particle, okay, that's about 500,000 particles. We have 300 times 10 to the 9, okay, pre-terminal arterioles. We have 300 times 10 to the 12 capillaries. So we are blocking 1 out of 1,000 or 1,500 pre-capillary terminal arteriole. That's why it's a safe study, safe. Okay, and but if you use a MAA particle, natural albumin particle, then you often see this hotspot. It's when you're infiltrating vein things, it's immediately this albumin particles attached to this blood clot. It shows hotspots. Okay, but if you use a synthetic and microsphere, you rarely see this kind of things. So in liver hepatic arterial perfusion using caster, you must use the synthetic microsphere instead of MAA, because this particle will stick to the caster. Now this kind of a posterior oblique view are best. So you can see very well delineation of the margin of the right lung, left lung. This is called stripe sign. If you see all good line, the chance for pulmonary emboli is very low, because of pulmonary emboli blocking arterial branch will make a sort of a wedge shape defect. So that's why this oblique view is the most important view. This right posterior oblique, left posterior. Center already show we define the defect, because pulmonary artery, directed pulmonary artery vein, you have fluid attenuating photons directly imaged. Okay, anterior, this anterior, and then posterior. Aortic arch often show attenuating here. Now sometimes you see little bit of activity in the kidneys. That means either intracardiac, like a VSD, a tetralogy follow, or intrapulmonary in patient with cirrhosis. This particle is shunting through the capillary. Then you must take a brain to see capillaries blocking anything. So we calculate this how much extra pulmonary out of total amount. And so we can here you outline whole and the brain things and calculate. If a brain has more than 6%, you have a potential problem. There were 4 cases of stroke developing after lung scan, but very rare chance. Because when you have a known patient with the blue lips, like an anemic tetralogy follow, you must use a 1 millicurie instead of 5 millicurie technetium 99 MAA, and inject slowly, watching patient. Okay? I've done many cases and nothing happened, even though we know cardiac pulmonary shunt. And now, see, these lower lobes are much bigger than upper apex. So there are more ventilation, more perfusion in the lower lung, but VQ ratio is opposite. VQ ratio is much higher apex, VQ ratio. Okay, that's a physiological. So here, okay, we have this old slides, so color is changing, but message is same. Ventilation doesn't show any particular visible defect, but perfusion show like a defect. So some old technique is sort of a subtraction, makes this kind. So you know, oh, this is a VQ mismatch. Now you can see all segments, so oblique, posterior oblique, all you see this is a dependent posterior, basal, superior segment lower lobe are most common for pulmonary emboli. Certainly this kind of lateral basal, anterior basal is also, but very rarely this apex things. So you have to know the segments clearly on the lateral, anterior, this oblique view. So you need all oblique or SPECT system. Now see, Xenon study show wash in, wash out. Equilibrium, 1 minute, wash out, very fast. But sometimes you see some activity in the liver if a patient has enough fat. Xenon 133 gas attached to the fat. So this suggests some fatty liver. MAA shows stripe sign, good stripe sign. So this one is almost normal. I call very low, less than 1. Okay, here again, very good, good. Okay, this is all another view, whole things. Okay, but here, the ventilation, wash in, wash out. A little bit is maybe left in the lower lobes, but you can see bilateral, multiple segmental perfusion defect, you cannot match with the abnormality on ventilation. That's a classical high, probably high above 80%, okay? Again, good, wash in, wash out, multiple. So it's a high probability. I usually put down number because surgeons like a number. When I initially report high, they call me, how high? When I put down 90%, oh, that's great. So even though high probability means above 80%, if a patient is on the internist care, then I call 90%, okay? But if this is a surgeon's care, it's 80%. So play politics is important in this kind to getting confidence. So it's a PIPET 2, or everybody agree, greater than 2 mismatch, high probability, high, that's it. Stripe sign, all other things is very low. Not absent, I really call absent PE, that kind of absent, small emboli you cannot show. And then, okay, when you have a certain elevated diaphragm or some pleural effusion, you see defect, but that rarely show high probability. That's all low probability. A lot of studies show certainly pleural effusion can be due to pulmonary emboli, but to call high probability, you have to multiple bilateral, not just one area. Certainly certain atelectasis, other things. So one area, one segmental is also low probability. So you have to look for other some core, certainly chest X-ray is a base, but chest X-ray doesn't show certain mild bronchial or parenchymal disease, so CT is better thing. So this kind of sort of a segmented, fragmented lung. This is maybe small multiple perfusion defect, but these are not the common high probability. Usually COPD, other things, causing a sort of indirect response of perfusion. And now this stripe sign I mentioned, this kind of thing, you can see already a certain ventilation studies, patchiness, whole thing is a sort of bronchial lesion. And now you can see ventilation study uniform. There's either gas or DTP aerosol, you know, but here all thing patchy. One side, perfusion show nothing here. And so this kind of thing, perfusion is worse than this one. And certainly, certain small emboli, other things, multiple may do, but that's rare. This kind of things are more likely. Certain bronchial lesion, particularly lung cancer, other things, and that will shut down whole perfusion. this kind of one side unilateral, unlikely for hematological pulmonary emboli. Usually central is a bronchial or central sort of extrinsic compression of pulmonary artery by tumor, other things, and whole consolidation or fluid. Usually cancer is the most common. And certain this may planar, some speck, this a horizontal speck usually show easily. So this kind of mismatched spexity has shown better, but excuse me. With the principles I mentioned, usually this planar can give either high probability or very low probability. This again, one side nothing, and show here as so either bronchial or central pulmonary arterial, certain extrinsic compression show this kind of thing, but not intrinsic hematological pulmonary emboli. Yeah, these are all cases. Okay, I have to probably move fast. Yeah, this SPAC show sort of better pinpoint a certain weak mismatch. So in the treatment, usually heparin and coumadin. And then certain very acute ones, certain we can give this thrombolytic agent like TPS, tissue plasminogen, and that's within the first 24 hours. Okay, treatment, usually low molecular weight has a less side effect. And it's thrombin also used, as I mentioned now. In lung cancer, surgeons remove anything they see on the picture. So resectability is beyond the question. Only concern is operability. A patient has underlying COPD, underlying a lot of lung disease. When they remove a whole lung or a low, big lobe, then patient dies of pulmonary insufficiency. So they have to know a predictive sort of a lung function after either a pneumonectomy or lobectomy. So we use the FEV1. They usually do a routine lung function test. FEV1 usually is greater than, normally greater than usually 2-3 liters per second. And after surgery, we have to maintain at least greater than 1 liter after surgery. So we divide. For lung cancer, pneumonectomy is best, but if they cannot remove the whole thing, they usually remove upper or lower lobectomy thing. So computer look at and then ratio, and then they divide into 2 or 3. So remaining is just a ratio of proper, and then times with the FEV1. Therefore, if that remaining lung has a FEV1 greater than 1 liter, that's operable. That's very useful information for surgeons. So we divide into 2 or 3 and calculate it. Now, thromboembolic disease can occur in the blockage of middle cerebral, anterior, or many things. So perfusion study, dynamics, stress, all things we know. Okay, and then certainly carotid. There's a carotid space here, and some blockage here, and then inflammatory macrophage takes up FTG, so we can inflammatory certain blood clot can show, and then certain reports show this certain investigative study also show this kind of inflammatory lesions, and then this plaque evaluation by near infrared and research, but often macrophage, other stuff. Also, I'll stop here. If there is any question, you can, as Professor So said, send an email or whatever, and then I'll try to respond to you. And there's a very famous from the opera. This again, Faust opera. So I hope you keep safe, healthy, and enjoy your learning or work. So if you don't have any urgent question now, and I will see you next week for more interesting talk on imaging of infection or inflammation. Thank you very much.